But introducing Krista Kane. Krista Kane is our director for academic programs and affairs for the department. She's been here since the, shall I call it, the revolution of 2009, and was really, I mean, I saw her working very much hands-on with the rebuilding of the department, and whether you're aware of it or not, I think she did a lot of the behind-the-scenes administrative and other work getting these programs established again and credentialed, helping to get them credentialed properly. Now she's talking about an intriguing topic now. I think she's always had a flair for a little bit of, well, what's that kind of title? But I suspect that it has something to do with a subject that she's very expert, because she has 5 girls of her own, and I think she probably has a lot of insight into this topic. So, Krista, the suspense is killing me to hear what this is about.
Thank you so much, Dr. Nada. Good morning, everybody. I'm so grateful to Dr. Bowling and Dr. Kalen, Dr. Nada, for having me here to speak today. I've been the academic director in the department for about 2 years, and I started as a residency program director, coordinator under Dr. Nada's directorship in 2009. So we have had some adventures in the department, and just trying to make things work. It's been hard work and really rewarding. And as a non-scientific and non-medical person, I've always felt very supported by the department, by the leadership of the department. So Dr. Bowling, Dr. Nada, Kalen, Dr. Williams, Dr. Hodes, all have been very hands-on supportive of my work in a totally different area. So I'm really grateful for that. And as we're getting into kind of a different time for medical education, we are seeing more encouragement of a partnership between the humanities and medicine and science, and hopes that interdisciplinary work will give us a different perspective on patient care, health, disease management. So I'm so pleased to come today and talk about my topic. I'm a PhD student on the other campus in humanities. I'm all but dissertation at this point. And really, I came to a late in life PhD program because I wanted to challenge myself to see things differently. And I really have had that experience. I've had the freedom in humanities to explore a little bit and choose my own direction. And I knew that I was interested, in the broadest sense in social justice. And as we began to work more connectedly with physical medicine and rehab, and we moved into Fraser Rehabilitation Hospital, which is where our offices are, I saw that there was this fascinating culture and some really interesting, really smart people working on the problems and issues in rehabilitation and spinal cord injury. So I was drawn in. I really was. This presentation is based on a paper that I gave last week at UCLA at a gender conference there. And the reason that pleasure came into the topic, I mean, it was always there a little bit, but one of the aspects of their conference was about the right to pleasure, which I think we're seeing more in the mainstream media a little bit, certainly scholarship, as connected to what we consider disability. And what I'm going to do is initially kind of break down the interdisciplinarity of my project as a whole, so that the building blocks kind of are more apparent, and then get into the paper and work my way through it with some commentary. So I encourage you, if you have questions about it, please do ask. I'm very interested to see, how this kind of topic sounds to a group who really works more in science. All right, so we'll start. So in humanities, interdisciplinarity is really the norm. So that is how we build arguments, by finding different disciplines and asking them to work together to give us new knowledge. So we look for evidence in different disciplines according to the discipline. So certainly I'm very familiar after my time here with scientific evidence, evidence from research, very quantitative work. What we do is we select evidence based on sort of the rules or the norms of the discipline. So in my sort of experiential look at spinal cord injury, where I've started is with, you see subthesis 1, which is from philosophy, looking at critical theory, which is critical social theory. Axel Honneth developed quite a body of work on recognition theory, so understanding how recognition plays into people's sense of acceptance within a culture and within society. So my premise, my thesis from critical theory is that women with spinal cord injury are socially invisible in the culture. The second subthesis is from philosophy also, but looking at phenomenology, which is about understanding the structures of experience. How do we have experience? How do we understand our own experience and form ideas about those experiences of others? So I look to Maurice Merleau-Ponty, who's a French phenomenologist, and I posit that the social and experiential effects of spinal cord injury are analogous, in fact, to the physical effects of the injury. This photo down here is of the artist Sue Austin, who, among other endeavors, uses her power chair to paint, both indoors and out. Third subthesis is coming from television programming, looking at medical discourse, and literary criticism, especially feminist psychoanalytic criticism. So here I look to Judith Butler, and I note that as evidenced by such texts as medical websites and the 2012 reality show Push Girls, the materiality of the body is dictated by the dominant culture. On the surface, the series appears to be a breakthrough representation of women with spinal cord injury, but the show retains many stereotypic representational themes about women. The last is back to philosophy, looking at ethics. Julie Allen, based on Foucault, says that the ethical project of inclusion is driven by desire. An ethics of inclusion can be enacted that relies on a desire for change to all involved. In this crucible, as an ethical project leading to politics of desire, ground zero is identity as it relates to the materiality of the body. Women with spinal cord injury must be encouraged to transgress, to explore their desires, and change then is framed as a focus on the self, not the other. But it doesn't stop there, because Allen bases this project on moral philosophy. Her use of Foucault builds on the Western philosophical tradition of self-examination and self-improvement as a basis for the motivation to examine and improve one's own relationship with inclusion, regardless of what position you have. So I was very interested in, as I got further into the way that we construct disability in our culture and in other cultures, I realized that I had to understand my own relationship with ableism. And of course, ableism is at the surface, it's a discriminatory approach to people who we consider to have, especially a visible disability. I think we're all subject to ableism in different ways, and sort of waking up to that is what I became interested in doing this work. In 2008, my closest friend Jane, a longtime teacher and librarian, went outdoors during a terrible windstorm and was struck to the ground by a falling tree limb. The weight of the limb snapped her spinal cord and a protruding branch pierced her skull. She suffered a simultaneous spinal cord injury and traumatic brain injury. Recovery from neural injuries is long and slow. Although she may never recover the function she had before the accident, my friend continues to progress 5 years later. It was in witnessing her treatment, adaptation, and recovery that I began to learn about what it means to be a woman with a spinal cord injury. The medical aspects of the injury, the rehabilitation and therapy, the dramatic changes in relationships and identity were significant. What I noticed most markedly, though, was the struggle against attitudes and misunderstandings, as Jane disagreed with the limitations and expectations she encountered as a woman in a wheelchair. So my work here, my research, and I'm just at the beginning of the dissertation, is rooted in disability studies, which started in sociology and has sort of gravitated into the humanities. I became interested in spinal cord injury because of my personal relationship with someone who sustained a spinal cord injury. And then also it's been nourished by being in the environment of the department, where so much attention is given to really understanding spinal cord injury at every level. My hunch, based on my own experience of my friend, was that this type of traumatic injury creates a social rupture. And I really wanted to dig into that and understand how we can understand, as people around a person with spinal cord injury, what that means and how best to try to support that person in coming to a new place socially as an injured person. I look to visual culture partly because I have a great interest, long-time interest in art and media, but especially because I think that so much, especially these days, our visual culture, the media, the magazines, the advertising, Facebook, really tell us a lot about the society that we're in and tell us how to think about it, I think, too. The special circumstances surrounding women with spinal cord injury, an injury that affects predominantly men, make their experiences a prime starting point for examining the situation of women with disabilities, their perspectives, their status in the mainstream culture, issues of identity and access, and not least their attitudes toward, experience of, and right to pleasure. So about a little less than 20% of the people who sustain spinal cord injuries are women. And that's a significant minority. And if you look at that group in reference to the population as a whole, it's a tiny, tiny group. And I find that a really interesting opportunity to understand such a small group's experience and then extrapolate from that. Neural injury begins with an initial insult, triggering a cascade of damage from the site of insult through the nervous system as a whole. The secondary aspects of the injury, as the cell damage progresses through the system, like cracks through a frozen lake, are more devastating than the first traumatic blow, as nerve cells are marked for inevitable death in a process that is difficult to arrest. The wound is merely the tip of the iceberg, signaling a far greater injury beneath. Mimicking the path of physical injury is the injury to the social being, which is ruptured in its connectedness as the spinal cord is ruptured from its neural connections. The body has long and perhaps always complicated the study of women. Women's status in their cultures is imagined, determined, and dictated by difficult to govern formulae of performance, perception, biology, mythology, and anatomy. The category of disability further complicates this continuum of identity. We see ample evidence of this complication in U.S. visual culture. Women visibly living with any disability are rarely shown in advertising, television, magazines, or films. I will examine the 2012 reality television series Push Girls as a departure from this lack of representation of women in wheelchairs, probing it through the lenses of feminist psychoanalytic theory and disability theory to better understand whether and in what ways it might act as a new representation of women living with disabilities. Finally, I will engage Julie Allen and her use of Foucault to frame an ethics of inclusion in order to better understand the responsibilities of and actions available to all individuals in furthering recognition and full participation for people living with disabilities. As women are such a small minority of people living with SCI, the majority of the medical research and medical discourse related to this condition focuses on men. This reality, combined with the lack of visible representatives of this community in the mainstream culture, results in social invisibility for these women. A fact sheet available online informs readers that, quote, the effect of SCI on female sexuality is far less devastating than on males, and also that, quote, the physiological sexual responses for women are mostly internal and less conspicuous than in males, and therefore more difficult to study. The same document discounts female patients' accounts about changes in their own sexuality after injury. Quote, most of the information that has been reported is subjective, i.e. obtained by history from patients rather than from scientific observation, and is thus likely to be less accurate. This last statement effectively closes off the entire topic of women's sexuality and SCI, as the physical responses are too difficult to study and subjective accounts are not scientific. Well, clearly we have a different situation at Fraser and here in Louisville and certainly in the medical center. I believe that the understanding and the sensitivity of the environment really helps to lessen the feelings of alienation and the feelings of being disabled that people have when they're in the environment. But we have to remember that all environments are not as evolved. And certainly the quotes that I just gave are from kind of a spinal cord injury informational checklist that's available online. So for some people, that might be the first encounter or the only encounter that they come to when looking at this issue. And I think it certainly deserves a better treatment than that. Axel Honneth, a philosopher working in critical theory, writes particularly about issues of power and respect in society. After Habermas, he asserts that invisibility is the lack of social recognition and that recognition is necessary for self-realization. Quote, recognition possesses a performative character because the expressive responses that accompany it symbolize the practical ways of reacting that are necessary in order to do justice to the person recognized. You see here in this photo, this is a picture of Esther Vergeer. She's a Dutch tennis player. She's now retired, absolutely phenomenal, really couldn't be beaten. And it's been interesting as I've looked at representations of disability, because in our culture, the social category of athlete is a very stable category. We give a lot of attention to that category. We like that. It makes sense to us. And so the more that you see of adaptive sports, the more amazing feats that we witness in the Paralympics and other kinds of competitions, that really can be a bridge and gives people with disabilities kind of a secure foothold. But for people who aren't in sports, there's still kind of a blank, there's still kind of a null as far as representing people living with disabilities. Honneth clarifies what he means when he maintains that human beings require recognition. He distinguishes between the German Erkennen, which refers to cognition or the apprehending of a person's presence in a way that is receptive, and describes the perceiver's incorporation of the person into a cognitive framework in the perceiver's own mind. This is in contrast with the vital and subsequent Anerkennen, which is productive and refers to the perceiver's active social acknowledgement of a person, which serves as affirmation and public recognition. The experience of living as a woman with spinal cord injury is not given sufficient attention in either the medical or mainstream communities, a reality which equates to lack of recognition. As Honneth asserts, recognition is necessary for self-realization, and the effect of this lack is that women with SCI fall into an uncertain territory of identity. So this was a really fascinating structure for me as I've been working in this problem, because how I think it can be viewed is by giving a good basis and understanding of what the responsibility for able-bodied people is in the culture in relationship to people with disabilities. So it is not enough to content ourselves with knowing that we hold no prejudice against a person with disability or that we want to encourage them. but this actually needs to be active. And every time that we walk in the street or in the hallway, we need to be finding ways, without being hierarchical about it, to acknowledge socially the people that we see with disabilities. And again, the structure of disability is complex, and it sort of moves when you start to try to pin down what is a disability. Well, I think we know it when we see it, which is not really adequate explanation. But we do know that people who do have visible disabilities are seen differently. And, it's our ability to kind of bridge that gap and actually share more social recognition. In order to understand the barriers to recognition for women with SCI, it's beneficial to look to phenomenology and psychoanalytic literary theory. Merleau-Ponty theorizes that structures of perception, as they relate to the body, are shaped by the nature of the body as both body subject and body object. Quote, "It's by means of such body schemas that we're able to act intentionally in the world. And though they most commonly operate at a pre-reflective level, they constitute our sense of ourselves as corporeal beings. In this way, our human bodies only exist as we perceive them. In understanding the experience of spinal cord injury, it's helpful to incorporate Lakoff and Johnson in their claim that, quote, conceptual structure arises from our sensory motor experience and the neural structures that give rise to it. The very notion of structure in our conceptual system is characterized by such things as image schemas and motor schemas." So Lakoff and Johnson are phenomenologists and linguists, and they've written a giant book about the body and phenomenology. And what their core tenet is that really the way that we come to understand our own bodies is through our interaction with culture. So our sense of our own body has sensory motor evidence, but also is reflected back to us by our culture. So in order to shape a different concept of a body, we need to see reflection in culture of that different conception being acceptable. And the way that these two theorists kind of pare it down is down to actually linguistics. So it's language that gives us sort of the concepts and the conceptual buckets in which we put different things. And for instance, one of the things I've just started to look at in their book is that they talk about the metaphor of a purposeful life. And it has a lot to do with journey and taking action and being in motion. And it's so fascinating if you think about that concept of what a purposeful life is as sort of this journey of motion, and then you think about someone who is dealing with a disability which creates paralysis in some aspect of their body, and how we as a culture don't really permit that divide to match. We really don't allow people with disabilities to map to our concept of a purposeful life. So anyway, I'm working on that. I'll get back to you on it. Mm-hmm. Linda Alcoff has explored invisible identities, the ways in which individuals are determined and understood through perceived characteristics of their physical bodies. She writes, "Both race and sex are most definitely physical, marked on and through the body, lived as a material experience, visible as surface phenomena, and determinant of economic and political status. In this way, understanding of one's identity is based on the ways in which gender and ability are reflected in physical characteristics, which are automatically attributed to a culturally articulated category. The more unstable the category, the more unstable the available social and subject identity." So what I mean by that, and what she means, as far as I understand it, is that we do place ourselves, even subconsciously, in categories in the world. We think of ourselves as a student, we think of ourselves as a mother, we think of ourselves as an orphan. However, our culture has shown us that those marked bits of our identity are classified, what kind of concept they occupy. So it's interesting to see where the voids are, that we don't have enough categories to represent appropriately people living with disabilities. As we examine the language we find in the context of neural injury, physical rehabilitation, and paralysis, we find illuminating its experiential analog. After the initial trauma of a spinal cord injury, there occurs a secondary cascade of effects that worsens the damage exponentially. The online medical reference Medscape describes this. More commonly, the injury level rises 1 or 2 spinal levels during the hours to days after the initial event. A complex cascade of pathophysiologic events related to free radicals, vasogenic edema, and altered blood flow accounts for this clinical deterioration. Subjected Bodies, an essay in Foucault and the Government of Disability, suggests a social parallel to this destructive cascade. In this work, Sullivan describes the processes and protocols that are typically used to treat and rehabilitate spinal cord injuries as critical to the, quote, production of a paraplegic, unquote. He describes the way that medical power is directed toward producing a governable, productive body. He writes, quote, recently admitted patients to a rehab hospital spinal unit learn very quickly that they have not only lost the power to move and feel their bodies, they have in addition lost possession of their bodies in terms of knowledge and control. Attitudes in the medical establishment toward pain, recovery of function, and even the appropriateness of specific types of catheters for urination combine to communicate that a person's sensations, preferences, and identity are under the control of the experts. So I can see this being a little bit controversial because certainly there are variations in the amount of sensitivity that medical environments have toward this kind of injury and working with a person who has just recently sustained this kind of injury. But I think that it is possible that when we get used to what best practices are and we understand them and we understand why they're important to the body's recovery, we forget to engage the individual in their recovery and in their understanding of what has happened to them and how their recovery should progress and what kind of person they become after being injured. And I think, if anything, it's just good to be sort of awake and listening to this person who is certainly a patient, who is certainly a case, who is certainly an injury, but is a person and is going to be living a life that, thank goodness at this point, long exceeds the injury. What we're seeing in the research is that most of identity actually starts over in the case of a traumatic injury, and that's why I'm so interested in it, because in the case of SCI, as opposed to many other kinds of illnesses and conditions, this person has led a certain kind of life up to that point. They've understood their lives in a certain way up to that point, and this enormous trauma occurs, and they really begin again. And we see in the research that in addition to just learning how to do basic functions in a similar way to the way children learn to do them, the sense of personhood, the sense of self, the sense of purpose, the sense of relational identity to family, to friends, to caregivers is all new territory. And sometimes the reclaiming of a sexual identity, if it happens at all, can take 15 years or more post-injury, which is kind of like starting over. So it's really fascinating. This picture of the woman in the chair under the water, this is Sue Austin, and she's the artist from the earlier image with the paint tracks. And she worked with engineers to create a power chair that could operate underwater. And so she's done all these amazing photo shoots of herself under the ocean in her chair. Really wonderful. And there's a image that's a tribute to Dr. Nada of a pigeon neuron. This is a watercolor done by Mariam Paré, who is a painter. She has quadriplegia, and she was an artist before injury, and She worked to adapt her painting over many years, so she paints with a brush in her teeth. And I love this quote because it's so vulnerable. You know, she really describes the emotional place she's in. She says, I felt very insecure and socially awkward, like I was a stranger in my own body. And it was something that pained me a lot. When I did these paintings, it was an attempt to reintroduce myself to myself. A woman with SCI is invisible in the medical system in the sense that she is at once a paralyzed subject surrendered to the treatment protocols for her injury and also a null entity as a female with a condition that is gendered male. Referring back to the cultural articulation of identity, Judith Butler writes, my view in Bodies That Matter was that there is an insistent materiality of the body, but that it never makes itself known or legible outside of the cultural articulation in which it appears. This suggests that we cannot experience the body, cannot communicate the body, without doing so culturally. In this way, we can sense how a woman with SCI's own experience is culturally constrained, and that her attitudes, her ambitions, and her pleasure become lost, illegible. In an interview in 2001, Butler discusses the difficulties inherent in gendered identity in the context of transgender individuals. Becoming a gender is a laborious process of becoming naturalized, which requires a differentiation of bodily pleasures and parts on the basis of gendered meanings. Very often what is wanted in terms of pleasure requires an imaginary participation in body parts, either appendages or orifices, that one might not actually possess. Or similarly, pleasure may require imagining an exaggerated or diminished set of parts. So what she's getting at, I think, applies to disability in the sense of, again, there are these culturally understood sort of containers of identity. And if we are talking about being a man or being a woman, we have the sense that there's kind of one anatomic way to be that, and also kind of one sexual way to perform that. We have a finite set of concepts that we relate to those identities. And for a person who is transgender and is actually moving toward a different identity, they sort of have a constrained set of options for enacting that. And if they actually don't have the parts to do that well, then there has to be an imaginary sort of activity that fills the gap. And I think that it works for the transgender person in this case, but also for the culture, that we don't know how to imagine things differently than within that constrained set of requirements. Butler's attention to body parts in this passage can relate to identity and gender in disability as well. As she suggests, a person can achieve gender recognition only by occupying a culturally recognizable category. In order for some gender identities to occupy such categories, a measure of imaginary transformation is required to make the body parts match the requirements of the category. Not only does a woman with SCI have to demonstrate in the mainstream culture that she can occupy the category of woman with all its ambiguity, but she also must demonstrate that she can occupy the category of person, as she inhabits a body living with paralysis. A woman like Jane must defend her performance of both personness and womanness before she can even reach the possibility of a sexual identity, and for many, it's easier just to give up. With a couple of noted exceptions, medical experts have paid little attention to female sexual response, sexual self-esteem, and relationships in SCI. Recent survey and laboratory studies of women with SCI and other disabilities have begun to generate data on sexual self-esteem, sexual interest, activity, and behavior. One study in particular at Rutgers was based on women with complete SCI, relaying their lived experience of sex and pleasure. The study elucidated that the ability to communicate sexual needs and desires came with an increasing sense of self and value as a human being. Although the women had regained their sense of identity as people in the world, their sense of sexual identity lagged years, even 15 years post-injury, behind this other sense of self. Paralyzed women must navigate the same series of identity checkpoints that can paralyze any woman, performing the roles of person and woman, the acceptability of experiencing sexual pleasure, motherhood, while trying to discern which are the expressions of sexuality, pleasure, or agency that might render her invalid and invisible, nullifying previous checkpoints and bringing her back to ground zero, the site of injury. The 2012 reality show Push Girls, which was originally billed as the opportunity to meet 4 friends who don't let their wheelchairs define them. The show depicts 4 women with spinal cord injuries who live in California: Audie, Tiffany, Angela, and Mia. The women are beautiful and stylish in the mainstream runway model Hollywood sense, and they have varied careers and relationship statuses. Although some aspects of the show's content are stark in their ability to illustrate some of the real challenges of living with paralysis, such as relying on a romantic partner to help with toileting, some of the others seem less real and more typical of some earlier reality show examples, such as the Real Housewives series. The glamour of the group is somewhat suspect, recalling the Mattel Company's 1990s introduction of Becky, a wheelchair-using Barbie doll who was not able to fit into the Dreamhouse elevator. Rosemarie Garland Thompson, who theorizes disability, suggests that women are the proper object of the male gaze, while disabled people are the proper object of the stare. The Push Girls representation is complex, and the questions it raises beg the issue of whether viewers are invited to gaze, stare, do both, or engage in some entirely separate response. Oop, how do I get out of here? Here. Sorry about that. Here's a clip from the show, and we'll talk about it.
I think in LA there is pressure to look your best. People are very image oriented out here. Let's go hook that rope up and do some of these little pull down things. Why isn't it coming down? It usually comes down when I do that. I should lasso it. Yeah. Awesome. Thank you. Awesome. Okay. Now we're not letting this go. Being in a wheelchair does create an image in other people's minds. So I think it's nice if they see somebody that looks like they've taken an effort in their appearance. I think most people haven't seen sexy in a wheelchair, and that's why they can't fathom it. Being yourself is really sexy, and confidence. That is a huge turn on.
Thanks, Paul. Thank you. Okay. So if women live their bodies as objects for an external gaze, how then do they live bodies that deviate from an ableist norm? In this clip from season 1, episode 1, Everyone Stares, Mia and Tiffany go to the gym to work out. Mia explains the image consciousness of Los Angeles and points out how this conflicts with stereotypes of appearance in people with disabilities. Mia and Tiffany clearly represent their fitness motivation in terms of appearance in this segment. This is another example of women producing their bodies to meet an accepted norm, right? Except that these bodies do not and cannot meet that norm. She can't hide that chair. She can't hide that she's seated half the height of the people who walk by, no matter how many reps she does. Still, the workout scene does not have an air of desperation or lack, but instead suggests pride. When the pull-down machine is stuck with the pulley clip at the top, inaccessible, the women do not register shame or helplessness, but instead Mia gives Tiffany a boost so she can reach up to grasp it. When she succeeds, they enjoy a second of celebration and then get on with the workout. Examples from common ableist language like handicap, confinement, disabled, crippled, dependent, paralyzed are simply not the first words that come to mind when viewing this scene. So there's been a little bit written now about the show, which has gone into second season. So there are 2 seasons of it. It's on the Sundance Channel. And this is from a blog on the Christopher and Dana Reeve website by Alan Rucker called The Myth of Walking. And he examines, what does this representation mean? How should we understand this in the disability community? And he says that it's either a distorted or even an unhealthy glamorization of people with disabilities, which has certainly been expressed, related to just how sort of fancy their life appears to be. They have these great evening gowns, and they're all over town, dancing and modeling and all kinds of things. So that's certainly worth registering, that sense. But he says, or it could be reflective of an emerging post-ADA generation of self-starters, or maybe it's both. The wheelchairs in the show, for instance, are designed to be seen, sporting decorative rims and seats. They lend intention to the reality of using a chair. The message is, I do not live paraplegia or quadriplegia in the way it's conventionally produced. I live this body as I see fit. I'm not a woman in a wheelchair. I am the woman who rides these custom rims. There's a confident rebellion at work in this series. We see Mia and Tiffany and their friends incite a collision between the stare and the gaze, rendering both inadequate. The push girls are creating a distinct identity category for women with spinal cord injuries. The push girl category may even be stable enough on which to anchor a right to pleasure. They are working at ground zero. Julie Allen engages Foucault as a philosopher of difference in the area of practices of the self and transgression. She theorizes around the problems of the special education system in the United States, using Foucault to problematize issues of power, resistance, and desire in this arena. Allen suggests that the facilitation of inclusion requires transformation on the level of the individual in order to create progress in the system. She maintains that substantive change will depend on allowing disabled individuals to shape their own identities by subverting the norms which compel them to repeatedly perform as marginal. She posits that individuals must desire change and seek to examine the barriers within their own consciousness that keep them bound to a particular response. For inclusion starts with ourselves, and that inclusion is not a project that we do to a small group of individuals, but rather something that we must do to ourselves. It is clear that the barriers to recognition and full inclusion for women with spinal cord injuries are complex, and that possibilities for change are also complex. The female SCI population is a small, marginalized minority that experiences barriers that are exacerbated by the societal barriers faced by all women. The right to pleasure for these women is eclipsed by the struggle for the right to full representation, but the paths to realizing these rights for all women are intertwined. All right, any questions? Thoughts?
Krista, first of all, I congratulate you on bringing this to this arena, because I think, so often we have a lot of discussions about hard data and managing the medical and surgical issues that relate to neurological problems. But, I think sometimes we forget that we're taking care of people, and that people leave the hospital and go back to lives that are sometimes very different than the ones they led before. And this is a prime example of that. The thing that has fascinated me for a long time about society and kind of response theory is not just the very different experience that the person with the disability has, and trying to kind of reorganize their thoughts about who they are and how they fit into society, but has been the long-standing problem that society has had, and us included as healthcare providers, about how we interact with individuals who look or appear or act differently than what we think is norm. And so, that includes everything from ignoring them and making them invisible to being very awkward in the way we interact with them, or limiting our conversations to certain things that are very superficial because we're afraid to say something that might embarrass us or the person. So, and I think that social awkwardness starts at a very early age. We see kids in the preteen areas who often just go up to people and say, "What are you in that wheelchair for?" Or "Why do you walk that way?" Or, "What's going on?" And it sometimes opens up a person to feel much more comfortable about talking about it in those cases, where at some point when you hit those teen years, it becomes suddenly very awkward to talk to or interact or socialize with somebody because you're afraid of embarrassing yourself or them. And so I think that one of the things that helps in this, and that's a reason why Fraser is a unique environment, is because we become more comfortable with those conversations. We become better at doing it, so to speak, and knowing what is okay and what's not okay. Although it's different, I think, for each individual, depending on where they are in their own recovery. But I think creating some kind of an environment or some kind of a course for healthcare providers especially, but really for all people, to say, this is what's kind of okay and this is not what's okay. Or this is how to find out if it's okay. Is it okay for me to open the door for a person in a wheelchair, or is that making them feel something less than they did before? And I think there's a lot of the unknown for the healthcare provider, and that's why sometimes the simplest thing to do is do nothing.
Right. Yeah, I agree with you, certainly. And I think that absolutely more public education is it's a good bet. And I reflect on, I went to public school here and I had hundreds of teachers, and I never had a teacher who was in a wheelchair or had a visible disability. And I'm curious about that because what it would have registered in my own understanding as a totally viable option, and made me more comfortable understanding that a person in a wheelchair is a person. And I think that's what you're commenting on, is that we just don't normalize this kind of experience. We don't normalize disability. We have a lot of it. We call it out a lot, but we feel awkward about it, and it's just because of experience. It's because of ways we've been led. I mean, fortunately, in our culture, there are other cultures internationally that see a visible disability as some kind of curse, within their culture. I mean, it's actually a bad thing, and these people are ostracized. I think that we see a lot less of that. That is not the general attitude in our environment. So we're further along, and we're at a place, I think, in our development as a culture where we're ready to be more inclusive, and a lot of people just want to know how.
Yeah, I think the fact that we integrate is in the school environment more children with both learning, developmental, and physical disabilities, all I think leads to a better understanding on the part of other children as to how to interact. So that I've seen that in my own children's education as being a positive thing. But I've also noticed that my kids in particular, because I've sometimes bring them on rounds or into the hospital, or they see a lot of people in wheelchairs or with different types of situations going on that would otherwise make somebody else uncomfortable, makes them less uncomfortable than it does. And I think, like you said, it's just a matter of exposure and interaction in many cases to say, number one, I recognize you as an individual, as a person, and that it's okay to talk to you and recognize you in that way and value it that way. But it takes that exposure to make that happen. Mm-hmm. And I don't know that we even do a good job on the healthcare provider side. I mean, when you look at a person with severe COPD, you don't think of them necessarily as a person with a disability, mm-hmm. even though they may not be able to walk across the room without taking lots of deep breaths and having to stop. But suddenly, if a person's in a wheelchair, there's something unusual and awkward about that. Mm-hmm. And so I think we need to do a better job within our own educational systems and in medicine of teaching people how to do a better job of interacting with their patients.
I feel that providers are constrained in many ways. That's the one thing about working in healthcare that I've really come to, is that all sort of exceptions aside, there are a number of people who come to the healthcare system for help, and there are a number of people who come to it as providers and professionals to help people. And the barriers between them are many and complicated, and that's sort of stunning when you really get a sense of it. But I think that the more that providers are given room, and of course it takes time, right, which you don't have in the exam room or in other scenarios, but being able to interact as much as possible with that person as a whole person, and making sure to ask questions about how things are going, not just in, is dressing getting easier, is bathing getting easier, but, how is it going? How's your relationship with your parents? What are you into? What are you doing outside of self-care and outside of going to the doctor and going to therapy? What are the interests? Because this is clearly, to me, an issue of identity. And so the stronger that identity is for the person, the better off in general they're going to be.
So, Krista, we have specialists in almost everything now.
Yes.
And so you have this whole spectrum of people that have been spinal cord injured, and so they have this whole spectrum of attitude towards their injury and their sexuality, and then you have this whole spectrum of providers. Seems to me like the spectrum could match or mismatch pretty easily. Mm-hmm. And I just wonder, with the concept of a specialist, are there people that, when things aren't working out in the match, are there people that can kind of pick up the ball and from the provider side, maybe have some more universal interest in dealing with the whole spectrum of the problem?
Right, it's a great point. And certainly, there's a strong psychology department at Fraser, as there are in all well-established rehab hospitals. And making sure that people are connected to those resources can be, an easy first or second step in making sure that their needs are accounted for. But I think that we just have to become more comfortable with talking about what we used to think of as the personal life of the person, which is separate from the medical life of the person, and realize that it's all interrelated, and that health is a little bit broader than we used to think, and that the contributors to health include just sense of well-being and connectedness.
I think to Dr. Nada's point, when a patient says, "I don't like my doctor," it's usually because they don't have a good relationship with their doctor. Yes. It's not because, it's very rarely they say, "My doctor's an idiot and doesn't know what he's doing."
Right.
If they say that, it's usually not because the doctor doesn't know what he's doing. It's because the doctor doesn't relate what he's doing, and so therefore there's not a good interaction. Right. And that probably is even more likely to occur if the doctor, or any healthcare provider for that matter, doesn't know how to interact with the individual because of the awkwardness that we just talked about.
Right.
And so I think Hank's point is a good one, which is, instead of saying, "Scrap this doctor, I'll go to the next one and see if they can interact with me better," maybe through patient interactions and patient satisfaction surveys, starting to learn and understand, what are the patient's experiences and how can we improve upon them through educating the provider how to better interact.
Exactly.
It's somebody who's done this for 20 years is going to be better at it than somebody who's done it for 20 months.
Right.
And so there's a learning curve. What's that?
He said maybe.
Yeah. And so, but that's not always true.
Right.
That's not always true. Sometimes the easiest thing to do, again, is to do less.
Right.
Because you just feel more comfortable getting in, dealing with the issue, getting out, and you leave the patient feeling somewhat less than taken care of. Right.
And Dr. Bowling has just recently, in the last few weeks, asked me to lead a patient experience initiative in our department. And, his attitude toward that is that there are things that we're missing in the patient experience. There are things that we can do differently and shift around and do better to make that person's relationship with us on the clinical level just better and fuller. And so we're doing, in neurosurgery and in PM&R, we're doing a self-study right now of exactly how we do what we do and how people take it in. How do they experience when we think that we're doing a great job in the exam room or in triage or whatever? How are they experiencing? How does it feel? And I think that we're going to tease out some of those gaps that you're referring to and find the opportunities for different staff training, different provider training to get people through those interactions rather than having to avoid them. Anything else?
Well,
Thank you.
Thank you.
I appreciate it. I appreciate your time.